Okay, let me call you back.
Miss Poplar, I'm Dr. Judith. How are you feeling today?
Terrible.
Terrible. What's going on?
My chest hurts and I can't breathe.
How often do you run out of breath?
When I get up.
Get up. All right. Well, looks like we're gonna have to increase your medications, your albuterol and your Atrovent, and it sounds like you're progressing to the chronic stages of emphysema. So we're probably gonna have to have you on O2 all day.
No.
So Vegas, you can go to Vegas, but you're gonna have to take your O2 tank with you. And it's gonna be a little bit. We have to get some tests done. We're gonna get an ABG, and that's gonna test how well your lungs transfer the oxygen into your bloodstream and remove the carbon dioxide. And we're gonna get a chest X-ray to make sure that there's nothing else causing your shortness of breath.
Why? I have to go to Vegas.
Well, you can go to Vegas, but after we get our test done, and we get you with your O2 set up, and you have to stop smoking.
I don't think so.
That's the only way you can get that. But I'm gonna go talk to your nurse and see what she's got planned out for you. All right?
Susie Puff's lot is not going to Vegas. Once you get, emphysema is incurable. Once it sets in, it doesn't get any better. All you can do is treat the symptoms. And I know that there's people that smoke in here and they're in denial. You don't have to smoke for 20 years to get emphysema. You know, it's not one of the, it makes the chances a lot better. But that's the 4th leading cause of death in the United States. Watch somebody slowly drown, basically, or suffocate is a sad thing. Once they get on O2, they usually, you know, start off progressively get worse until they live on O2. I'm going to show you real quick. This isn't a radiology class, but this is lung tissue right here that is normal, and this is with emphysema. Okay, what happens is the spaces get bigger, and then actually they collapse when they exhale. As I said, the radiology people were nice enough to give us an X-ray of an emphysema lung, and if you look right here, on one of the other, I wish I had a healthy one to show you, but it's big, the barrel-chested. You'll see the big thoracic cavity that's just expanded and stays that way because they never get the air out. And all those little dots, if you look in there, are the alveoli that are expanded. It reduces the surface area for the gas exchange. Okay, and oftentimes in the X-ray, the diaphragm is actually straight across. It doesn't have any bow to it at all. And then over here on our nice poster. Go ahead, what?
Yeah, I'm going to go ahead and do the assessment for Dr. to the point, and we're going to do it with our nursing team here. And you are our nursing team. I should have Mrs. Nadal come up and help guide the group. We'll do it here. This is a synopsis of our patient, and it's written down on. It's the 65-year-old female Caucasian. Can you see that there? Where you're at? Okay. Oh, sorry. Admitted to April 18th for shortness of breath, fatigue, coughing, hysterochronic obstruction, COPD, AFib, and CHF. She's alert and oriented times 3. She's got cyanosis at the lips and at both lower extremities. Her vital signs are temp 98.7, a pulse of 67, respiration of 15, blood pressure of 120/60, and she's got a pain of chest tightness, a 7 on a scale of 1 to 10. And her on-air, room air stats are 89%, and they started her on oxygen at 2 liters per nasal cannula. She's got a chronic productive cough. In her lungs, she's got high Ralls and Stridor. Her skin is intact. She had a 5-second trigger there, and bowels and bladder are continent. Her diet, she's had a loss of appetite. Muscle weakness is at a level of 2 to 3, and social, she started smoking at 17 years of age, and she's down to a pack a day. And her lab values are a pH of 7.34, which equals respiratory acidosis. So with that, your handy dandy blue cards that I asked you to have. Does anybody have them? All right. So you're my nursing team, our nursing team. We're going to come up with some labels here from the information that we have on our client. So what do we have here? Anyone? Activity and tolerance, okay?
Impaired gas exchange.
Impaired tissue.
Yeah.
What was that?
Impaired tissue perfusion.
Okay. tissue perfusion.
Impaired gas exchange.
Impaired gas exchange.
And
Oh,
balance
wait,
nutrition,
before I do
that's
all
the
that,
one.
what are our cues here for the activity intolerance? What is it that's on here that will shows the activity intolerance?
Shortness of breath.
Okay. What else?
Fatigue.
Fatigue,
Muscle weakness.
muscle weakness. Oops. It is hard to spell up here. I feel your pain, Miss Tina. Okay. Muscle weakness. Okay. And anything else? That one? How about this impaired tissue perfusion?
Chronic
Sinus.
obstructive pulmonary disease.
COPD? Okay.
Sinuses.
And one more.
How about the most?
Where's your pulse? Yeah, 89%.
Pulse ox right here.
Cold feet.
Cold
Extremities,
feet. All right. And let's get one more label here. We've got two. We just need one more.
Impaired gas exchange.
Impaired gas.
You got three.
Okay.
Did
Oh,
you say
okay.
that? Impaired tissue perfusion, and you said impaired gas exchange. So it's up there.
Okay, got it.
And let's call that a
All right,
group project.
will do. Okay, just on the activity intolerance, what's a goal that you could have?
Maintain the level.
Maintain what?
Maintain the level.
Maintain current levels
I can't make better.
of O2?
Of activity.
Of activity, okay. And what's one more?
Be able to perform ADLs without getting any shortness of breath.
Okay.
Plan your funeral.
Four ADLs. Without SOB, okay. Shortness of breath, just clearing that up. Okay. And how about, well, that would that be a good long-term one?
Long-term
That could be a long-term one, and this could be a short-term one? Okay.
Yeah, definitely.
Well, you kind of get the idea there. That's how we would do it with Miss Nadal at the Life Care Center. We would do that at our post conferences, and thank you for being my nursing team to help come up with interventions for Miss Puff's a lot.
Okay, ready.